So should I put this up here, or if I do, will you still be able to see me? My little, that's what we're supposed to do? It's okay? All right. All right, good afternoon. I'm Terry Stancin. Thank you for inviting me to come and talk with you all today. I'm looking, is this the thing? I'm here today to talk to you about what we're doing back in Ohio. So we went from Ohio to New York to back to Ohio at Metro Health Medical Center, and talk about some of our really evolving programs in training interprofessionals to work together in promoting child behavioral health. Did I do something? Okay, so let me remind you all, if you don't know, where Metro Health is. It's in Cleveland, Ohio. You see it there. And in addition to being well known in Cleveland for having the Cleveland Cavaliers and the Republican National Convention and the Indians, this year we also have the dubious distinction of being a very poor city. In fact, we're one of the poorest cities in the country. 58% of the children in Cleveland live in poverty, which is one of the highest rates. We go back and forth with Detroit to having that distinction. So Metro Health is the county safety net hospital for the region. And we have a number of locations, but primarily I'm going to be talking about what we do at our main campus location, which is the largest hospital-based, and we have clinics associated with us right around us. We are an academic medical center affiliated with Case Western Reserve University. Pediatrics is actually a relatively small part of the general health system, but it's got a very big ambulatory practice with over 50,000 ambulatory visits per year. Most of the children that are served in these clinics are poor, insured by Medicaid, and it is a very diverse population. So associated alongside with the pediatric clinic is my division of child and adolescent psychiatry and psychology, and we are a small but mighty team of just 5 psychologists, 2 child psychiatrists, and 3 clinical social work therapists. But we have a growing number of trainees that really work to be extenders in our department. We're hospital-based, but we also have we also are a community mental health agency within the community, which really helps a great deal in allowing us to do some programs and bill for our services that are not always available to hospital-based training programs. And I say we're small but mighty because together we see about 10,000 visits per year. So for that small of a team, I think we are pretty proud of what we're able to provide. I was asked to give a bit of a timeline of my experience, I think partly because I've been at Metro Health for 30 years, so I can go back to 1986 and tell you a little bit about how we've gotten to the point that we are now. So back in 1986, when I arrived, I was a fresh PhD from Kent State, and I was hired to be part of a primary care training grant. Back in those days, there was a number of training grants that were given to primary care programs to try to enhance the skills of pediatric residents to take better care of the psychosocial needs of kids. And so I was hired to do that. The chair of pediatrics at the time had the vision of having a psychologist placed in the primary care clinic to help teach the residents and precept them side by side with a nurse practitioner and the pediatric preceptor. And that was our model that was funded for a number of years, and then really was sustained without external funding until 1999. During that time, we did have some psychology students from Case Western rotate through the program, but primarily I was there as a consultant to the pediatric residents. As an aside, prior to my coming to Metro in '86, we had a long history of having a psychology internship program, and that was stopped in '86 because the then chair of psychiatry felt that the $3,000 stipend per year that the interns were receiving was too costly, so the funding was cut. Fortunately, we have a psychiatry chair who's much more supportive at this point. But kind of going back to those days, so after 1999, when managed care came into place, I think that we really started to feel a lot more pressure to become siloed. And so I was then sort of, my support for being in the pediatric clinic precepting was replaced by a demand to try to build a division where we were seeing more patients in a siloed way. So out of the primary care clinic into the child and adolescent psychiatry sector I went, and there we were much more, a lot of emphasis on revenue generating and being separate because of managed care carve-outs and so forth. So we did have trainees, and we were still being involved in the primary care center, but it was really more of a distant, sort of co-located model and not really so much integrated in the clinic. There was always a lot of interest in getting back into the clinic, however, and so back in 2011, we decided we were going to really push forward and have integration in primary care again. And at that time, we started with a postdoc that was doing both clinical care as well as providing academic support to the pediatric residents. And then in 2013, we really have taken off. So since that time, we have developed a psychology internship, psychology residency program, which was quickly accredited. And also, we've been doing a full integration in our primary care clinic. Jump starting to today, we now have our third cycle of trainees. We've added a postdoc fellow, we have practicum trainees, and we've started a child psychiatrist consultation pilot at this point to also enhance the services that are there. So quickly, we have several training goals that we are trying to achieve. One is to increase access to behavioral health care for children in poverty. Back when we had our siloed situation, we had upwards to a 3, 4, 5, 6 month waiting list for services. So we really wanted to increase access for behavioral health care. We want to train psychologists in integrated pediatric primary and specialty care settings with focus on psychology trainees who can take care of mental health needs of children, but also address the issues of health issues as well, chronic conditions, obesity, health promotion, and so forth. We also have the goal of enhancing developmental behavioral skills of the pediatric residents that are there, and to prepare interprofessional teams to collaborate and work effectively as teams. Some of the highlights of our model of training is that Britt Nielsen, who's been our leader of the program, has really taken this to new heights. We have a sustainable model where our trainees are able to bill under supervision, which allows us to have the support of our administration. Our psychology trainee time is divided equally between time in the primary care clinic, specialty care clinics, and ambulatory mental health clinics. So they're getting a combination of experiences. We have a postdoc fellow who provides immediate umbrella supervision. Really importantly, we have shared didactic and teaching time with the pediatric residents, which we feel has been really important to having them learn together. We have pediatrician mentors for the psychology trainees and psychology mentors for the pediatric residents. We've started a new simulation team module this year, which I'll show you in a minute, a picture of that. And we've also started, as I said, the psychopharm consultation model. We're trying to really emphasize a program that is built on competency expectations, and so we're relying on a document that is in one of your handouts, I think, in the most recent Journal of Pediatric Psychology on professional competencies for pediatric psychologists in integrated primary care clinics. This is just a picture of our model where we have our trainees and other psychology and clinical social workers who are embedded in all of our specialty and primary care clinics. We have a number of services I'll just list here. These are pretty standard integrated care services that are provided by behavioral health professionals. And this, I want to have you look at this slide for a minute here, because I think this is a really important picture, a snapshot of what we're doing. Our psychology residents last year wanted to document our impact, and so they tracked for 6 months all of the clinical encounters that they had in the primary care clinic. And this is we have residents that are there covering 9 of the clinics. So there's only one psychology intern covering the entire pediatric clinic. And within that 6-month period of time, they counted 755 referrals for behavioral health consultations. Of those 755, the vast majority were actually billable encounters, so 71% were billable encounters. Some of them, the 25% in green there, were warm handoffs that were then may have led into billable encounters later, and a very small number were actually declined services. On the right side, you see another risk assessment chart. So let me tell you what this is. So in that 6-month period, there were 23 consultations requested of our trainees, which involved suicide risk primarily, but it's a danger to self or others. In the past, those patients would have all gone directly to the emergency room for a long evaluation that would not have been pleasant for the family and may have ended up in a hospitalization. During that 6-month time, of the 23 risk assessments, the interns were able to assess, stabilize, and send home all but 2. And the 2 that followed up with home care. So we felt that that alone was a really important picture of the impact and the increased accessibility. In addition, we completely eliminated our waiting list for mental health services with the introduction of trainees in our primary care clinic. We've started doing a simulated clinic because we really wanted to have more opportunity for our interns and our pediatric residents to learn using our SIM center how to work effectively in teams. And so this year we piloted a joint training where we had our psychology trainees and our pediatric trainees rotate through 4 different simulations with actors, with a parent of a 2-year-old with tantrums, a parent of a 13-year-old with diabetes, a 17-year-old with a history of suicidal ideation and depression, and a parent who was Spanish-speaking with a 12-year-old with asthma. And through this, you can see, I hope you can see, that we have our faculty looking through one-way mirrors at our psychology and our pediatric residents, trying to figure out how they're going to approach and manage these cases, and then team discussion afterwards. We haven't analyzed these data yet, but it was a very fascinating and very powerful procedure. So the lessons learned quickly, I think the importance of really taking a look at how economic and leadership changes can affect training programs is a lesson that we learned. We found that the ability to bill for our trainee services was really critical to sustainability, and I think that's a challenge for a lot of psychology training programs, is how to fund some of their training programs. We struggle sometimes with defining the roles of behavioral health providers so that everyone is really feeling that they're working at the top of their license, and how we can incorporate other providers to sort of work at their top of their license as well. Cross-disciplinary teaching and mentorship has been really very important. We're challenged to try to define meaningful quality and outcome measures that we can document our effectiveness. And really, I want to leave with this last point, which is that since we've had this program, we're really not sure if we're benefiting the resident knowledge in behavioral health or not. Some people have been concerned that having ready access to a behavioral health professional has actually let some of the residents off the hook. So maybe they're not learning all that they need to know about managing complex psychosocial conditions. We're going to have to evaluate that and see. And so I think I'm out of time. Thank you.